And move on to our 6.5 item, 10 a.m., consideration of resolution adopting the 3-year Lake County Mental Health Services Act program and expenditure plan for the fiscal year 2023 to 2026. And we have behavioral health. Come on up.
Do you have the clarification that you need, Scott?
I do, yeah, and I just wanted to thank the board for their
Okay.
consideration.
Sorry.
Just wanted to make sure you're still sitting there, so I wanted to make sure.
Yeah.
All right, excellent.
Still there.
Sorry, Scott.
That's all right.
Let's trade Scots here. You're walking better.
That's what I was thinking. Every week.
Right. Okay, Director Jones.
Well, thank you. Oh, hello. I do. Did you see the PowerPoint? Okay, great. Well, thank you. Thank you, Board, for hearing our presentation of the 3-year Mental Health Services Act plan. We just concluded our planning process. Every year we come to you with either an annual update or a new 3-year plan, and so this is that new 3-year plan cycle. The process, as you probably are aware, because you may have even come to some of the stakeholder meetings, involves significant stakeholder feedback. That's what drives Mental Health Services Act dollars. And so, timing. And with me, I do have Scott Abbott, who is the Mental Health Services Act Program Manager for Behavioral Health. And so if there are any questions as regards the presentation that I can't answer, I'm sure Mr. Abbott will be able to. You're doing great. It's fine. No, it's, you know what? I think there are ghosts in the machine sometimes. I think, can everybody, well, importantly, I suppose the folks on Zoom will be able to see it. Are you sharing the screen? Okay. All right. That's all right. Okay. No problem. I got it all. It's fine. Okay. So, I don't know. We'll just roll with it. All right. So, the agenda is today to look at, obviously, the background a little bit for folks who aren't familiar with how the Mental Health Services Act came to pass, and what the 3-year plan and community process, planning process looks like. Some prevention, early intervention, evaluation reporting. A lot has changed in that space, and they've made a bit more robust the reporting requirements for some elements of the MHSA. Program participation and our outcome data. Community needs assessment and findings from this most recent 3-year planning process, and the proposed programs and plans for this new iteration of the 3-year plan. Okay. All right, so we're going to talk about, first let me give some contextualization here. There are different buckets of funding with regards to MHSA, and so one of them is specific to training and education. And as you can imagine, that's a pretty salient issue for the behavioral health workforce now more than ever, for better or for worse. And so for background, of course, this is Proposition 63 we're speaking of, which was passed in November of 2004, and these are funds, again, that come from a 1% tax on folks, Californians specifically, whose income is over a million. And so these provided outline of the MHSA funding buckets. So you got community services and supports. That is the largest bucket of funding and also provides the most direct services. This is how we pay for a lot of housing supports and services for our beneficiaries. Then the second largest bucket of funding is the prevention and early intervention. Prevention is a big component of the MHSA, and rightfully so. Innovation, this allows mental health plans to experiment and throw some spaghetti at the wall and see what sticks, and maybe some good comes out of it. Workforce training and education, pretty self-explanatory. And then last, we have capital facilities and technology needs. This funds infrastructure support projects such as a new electronic health record. All right. So some important things to consider here with regard to the planning process. Oh, that is so small. So the biggest thing here, of course, is the stakeholders. And we work really, really hard. I'm emphasizing this heavily because we work really, really hard to engage our community and hear from them about what they want. It's their plan and their tax revenue to plan for. This is also in collaboration with our mental health advisory board. And so they actually host some of our mental health, that's what they're supposed to be doing. So that's great that we have that up and going where they're hosting that and convening those stakeholder gatherings. Of course, this presentation by the Board of Supervisors represents kind of the last phase of stakeholder feedback and input at that last level before approval. So what will happen is we'll present this. Hopefully it sounds reasonable enough, and you'll authorize the behavioral health director to sign the plan and submit it to the state and say, hey, this is what we're going to do. And then we start it all over again. Oh. Technological issues. I appreciate your attention to detail. We're on number 5, I believe. Yep, and then up there in the upper left-hand corner. Or no, you can just go from current slide.
Click on the notes situated below the slide and hide all ink on slide option. Like if you start the slideshow mode, click on notes situated below the slide. So you want to start the slideshow?
Right here?
Yeah. It's not showing the...
Well, what I can say is that the item does have the attachment. Would your board be okay with just continuing on, and I can talk you through this if you have it up in front of you, if that's sufficient for the community to be involved is my concern. But given that they have the attachment, theoretically, people could have downloaded it. Okay, so let's continue on then from slide 5. All right, so on slide 6, actually, we'll move on. Oh, no, back to slide 5, sorry. So we pay somebody to help us with this. They do a really great job. It's Resource Development Associates. Your board also approves the contract with the Behavioral Health Services Department for those consulting services. And I think a really important part about what RDA brings to the table is, because these are such large amounts of money, it's really important to us that we are neutral, and having a third-party entity facilitate this is certainly another way to ensure neutrality. So I got it. I think we're good. All right. Now, so number 6, PEI. So that's Prevention, Early Intervention, Evaluation Reporting. So this is just some footnotes, really. And the big takeaway from slide number 6 is that we're having some significant increases in reporting requirements for PEI, which is fine and good. And there's a lot more focus on data, again, which is fine and good. So what this reflects is an overall trend within the state of becoming more sophisticated with PEI programming. And so whenever you have sophistication increase, so do the reporting requirements, essentially, of the program. So I would say overall as a state, we're kind of looking into the future. Now here, well, I think it's this spring that there may be a vote, if it makes the ballot, SB 326, which would change Mental Health Services Act to Behavioral Health Services Act and change some of the funding allocations, so just as a foreshadowing of perhaps some changes to come. So on to Section 2, which is Slide 7, which is our fiscal year 21-22 program participation and outcomes. So we have many programs that are under our community services and supports, or our CSS bucket. So that includes a crisis access continuum. And I suspect here shortly that's going to change because of the requirement for mental health plans to implement a mobile crisis response effective January 1. So all mental health plans across California are required to implement this. And so I suspect that this may change as we, like many other counties, we're sort of building the plane as we're flying it, but because it is a short runway to the go-live date. We also have our Forensic Mental Health Partnership, and that is funded. This is also going to change here in 2024 because of CalAIM. And in 2024, under CalAIM, inmates within 90 days of release will be eligible for what they call pre-release services in the jail, which are Medi-Cal reimbursable, not only physical health, but mental health, specialty mental health, and drug services. So that will probably change significantly, and those funds will probably be reallocated since we'll be recouping quite a lot of funding from the provision of services, billable services in the jail milieu. And I'm pleased to say that we're working in close partnership. I want to shout out to Norm Taylor, who's always a really great partner, also Sheriff Howe, for Crystal Marketan, I'm probably forgetting others, but for kind of starting the process about talking about these things. So as I just move through here, kind of foreshadowing again where the trends are. Do I see a question for
Did
me?
you say will be or are?
Have been meeting about just
No. As far as the 90-day prior to
will be in
release.
2024.
I thought it was already in
No,
action.
no. So CalAIM was a slow rollout and justice-involved initiative. So first, what you have is you are required to do pre-release coordination so that upon release, they're immediately eligible for benefits, get warm handoffs. And then the next phase of that rollout for increasing services to the justice-involved population or incarcerated people really is to provide actually Medicaid reimbursable services. So that isn't happening yet. Yeah.
Is it January 1st?
It's 2024, and I don't know if it's January 1st. It may be, it's either the first or fiscal year. That's what it's going to be.
Okay.
But we're trying to wrap our head around it, and I think we're doing a good job. I think we're going to be just fine. A full service partnership. So FSP is probably our largest bucket of funding within the CSS program, and so that funds a lot of what the phrase is whatever it takes, pretty much. So if that's housing, if that's helping with school supplies, I mean, the list of whatever it is whatever it is to help a person be stable. And we have a lot of actually great outcome data on the FSP program about reductions in recidivism for justice-involved population. That's coming up perfect. Thank you so much. Older adult access, parent partner support. So in some of our teams, we have the integration of these MHSA-funded program positions. And one of them specifically is our program for early intervention for young people who are experiencing psychosis. And so as you can imagine, that's really hard for a family, right? And so even just as important, if not more important, honestly, sometimes, is providing services and supports to the family of that youth so that they can have that support in the home. And so the parent partner is a position that will pair up with that family and help walk them through the process of having a child with mental health or other needs. So really critical. We do a lot of work in the behavioral health space around trauma-focused or trauma-informed care. Co-occurring care, which means you have a dual substance use disorder and mental health issue, are really, really common. I don't think that's a surprise to anybody, so we do have specific programming around addressing that very big need in our community. Outreach and engagement. We do a lot of work going out into, like, for example, the schools, the communities, providing trainings, mental health first aid trainings. I know I just sent Chief Rasmussen over at Lakeport PD a link to potentially enroll one of their officers in a facilitator training for mental health first aid to pair up with our staff to provide law enforcement mental health first aid training. So that these buckets of money fund that kind of stuff is what I'm trying to say here. Also PEI, a wide range of different programs, and these again are more geared towards the prevention end of the spectrum. So these programs fund things like Motherwise, right, for postpartum. Also fund, what are some other examples of PEI?
Our biggest one right now.
Microphone.
Our biggest one right now is, or one of our main ones that's new is the outreach van that we're doing, where we're going out with a van into the community to particularly homeless encampments and other places where there's people identified as needing, doing actual outreach to them to help them engage into services.
Yeah, and that was a nice little seed money of cannabis grant funds that grew into a whole program. How fun. Okay. So innovation, we just concluded an innovation project around our full service partnership program. And one thing we found across the state was that the entrance and exit criteria for the program weren't really well defined. And we worked with a contractor to accomplish a multi-county work on that so we could compare notes across counties and got some good stuff out of that. Hi, Stephen. And so that is our buckets of funding. Additionally, of course, we have CAP facilities. So some of that money, not all of it, went to fund our EHR, new EHR. That was probably a blending of, I want to say, like 4 different funding streams, but this was one of them that helped. Also helps with our buildings, renovations that need to take place, things like that. And then workforce education and training, which I think is one of the hottest topics right now in the behavioral health space. And so actually through that program and a multi-county initiative, leveraging a lot of different funding, we're able to offer stipends and actually loan repayment. I was a recipient of one, actually a small one for our department. I paid off, woohoo! And our staff are able to access that so that education isn't so much of a barrier. Also looking at investing that in the lower levels. I hope everybody can really feel my air quotes because it's heavy emphasis on that. But for lower levels like case managers to get kind of certifications and build the career path. So there's a lot of energy in that and in the California behavioral health space right now too, which is very refreshing.
Yeah, we're particularly interested in growing our own. We found that if you can raise a workforce within the county, those people are more likely to stay in the county because of the roots that they have here. And so that will prevent turnover.
Indeed, we've been very successful. Okay, so next slide. Perfect. All right, so the MHSA program participation, this is a high-level overview of consumer data. So in our CSS programs, and remember that's one of them, the community services and supports that serves our full-service partnership folks, that's 300 folks that was served in fiscal year 21-22. PEI, because we're doing a lot of training, education in the community, we touch over 15,000 people in our community, providing valuable information or resources. We do a lot of work in the schools trying to avert substance use issues and things like that as well. That's in a different prevention space, but it's all kind of the same stuff. So a lot of great details there about dominant language, race, ethnicity, age groups. For your perusal, go ahead, next slide. Okay, great. So more outcome data, thank you. This is the slide to which I was alluding earlier because I love it. And so Scott, I'd like you to talk us through this slide, will you?
Sure. My glasses work correctly here. This is outcomes for our full-service partnership. Our full-service partnership, as we mentioned, it's the largest program we have for the Mental Health Services Act. It's designed for people that are in the most need, the most vulnerable, and it targets being able to help people through wraparound type of services and sometimes financial support for like housing and other things that are determined to be needed within the treatment plan. Through that, it helps people in their recovery. And what this data here recognizes is the first line right there, year one, is kind of the baseline data of where people coming into the program, where they kind of stood as far as number of crises, being in the hospital, those type of things. And then it shows through, the next 2 years how those markers decrease, that they're spending less time in crisis, less time in the hospital, less time, I'm not sure if this has homelessness or not, but they would be less time homeless. And so, which is really good. This is real solid data that shows that the programs do make a difference in people's lives.
And I think that data may also too reflect people who have been incarcerated. I know we did keep data on that, but for sure this is beds occupied, usually not in our community. We don't have a lot of beds in our community for folks. And so this is enabling people to stay in a lower level of care, which is independent living. And you're seeing, first at 18%, that was kind of the average rate of people who first got in. And then it cut down over half in 1 year in the program. And then the second year, half of that. So those are incredible data. So moving on to some more outcomes. So for our street outreach program, which is slide 11, this is just showing the amounts of referrals and services that we've provided, as well as the areas. The majority of the street outreach has taken place in Clear Lake, which makes sense. That's where the most of our people are. Following up to that, though, we do have Lucerne and Lakeport. And so people are, again, getting referrals to all of our services. But every time you see a 100% meal, that's because that's what they're doing. They go out there with their bag lunches or their meals, and they hand them out to people, as well as a variety of other supplies that we have. Oh, there we go. Okay. All right, on to 12. So, this is a shout out to our early intervention services program. And I spoke to this before. This is a program specifically for young people from about age 15 to 25 who are experiencing a first episode of psychosis or some kind of psychotic illness. And they worked with 20 children and 33 transitional age youth. So just call it, 53 people total in that program, which is a lot. To provide them, obviously, mental health services, but really wrap around their family and provide those kinds of supports that they need. And there's a lot of compelling research out there that shows that really strong early intervention can actually, you can't cure mental illness. It's not that type of disease, right? But you can remain asymptomatic and in remission for a very long time. And so that's what you're seeing with kids who get that really intense, heavy dose of treatment early on, as you see almost a nearly complete remission, maybe with some issues. So it's pretty sensational. And through this, we actually were awarded a couple of years ago a grant through the Mental Health Services Oversight and Accountability Commission for about $2 million. And part of that grant enabled us to expand programming, but also it linked us to technical assistance from the experts in the field from Stanford, from UC Davis, from UCSS. So we meet every month with these the forefront of the field to talk about our program and to also link with other counties that have similar programs and share data across counties to see what they're doing and what we can share, right? So that's been a really super fun experience for staff. It's a passion project of mine in our department, and this is one way that the Mental Health Services Act supports that program. All right, next slide. Thank you so much. Okay, so this is moving on to the community needs assessment findings. So we talked about what we've been doing. Now we're going to talk about where we're going to go. So what did we hear from our community? Go on, next slide. Thank you, Johanna. What we heard from, well, first of all, we had a lot of participation. So surveys, we got about 108 surveys, 155 people at community meetings that took place on 2 different occasions, focus groups, 43 people. So all told, this plan represents the feedback from 360 community members. Now that does include staff of the Behavioral Health Services Department. However, it's largely viewed, and I support this view, that staff are one of our largest stakeholder groups. They're out there providing the services. They have a lot to know. So you can see that reflected here is that a lot of staff, but also a lot of community members, and really happy to see a lot of consumers as well of behavioral health services. I think their feedback is probably one of the most important groups of feedback. All right, next slide. Okay. There's a lot to digest here, but essentially this is the needs assessment survey findings. So we asked people about the services that we provide, about the access to those services, and then their experience with those services. So you can see that most people are mostly satisfied. It's about the summary from this slide. There are always areas for improvement, and we're always working to improve all of these elements, the services that we provide, the quality of those, and access to them, the timeliness of care, of course, and then also how quality are those services, and do they feel helpful to the family? So this is really a great feedback that we do share with our department and our clinical teams to help improve services and care. All right, next slide. Perfect. So we do have some great strengths that were found. One of them continues to be our peer support centers. Scott has said before, they're the crown jewel of our department, and I think I'd like to argue that they're definitely amazing. And so we have been opening as well and partnering to provide cooling center support countywide informally as we work together as a county to develop, more permanent plans, right? So we're definitely, big thanks to our peer support center staff who take on those hours to make sure that our doors stay open during that tough weather. It just, especially our stakeholders and our beneficiary of those centers, they're just, you gotta go talk to them sometimes. It'll make you cry. Don't if you don't want to cry.
It's also our peer support centers, which are probably the most partnered with the continuum of care, the housing continuum of care programs. And they both work with a lot of the same folks. And so there's a great partnership, which I think would exist there.
Absolutely. Thank you so much, Scott. So we're also noted for being friendly and supportive. Service partnership and collaboration. We're really focused on not being redundant and not duplicating services and working smarter together. Also, our services are generally timely. Compared to other similarly sized California counties, this comes out in our EQRO data, external, or one of our audits. We do have pretty timely services. We work really hard to make sure transportation is available. We know that's a huge barrier. And we afford a lot of flexibility to our beneficiaries. Also, the availability of telehealth and virtual services is still something that's appreciated by the community. And truly one of the silver linings, I think, that we got out of COVID, us and everybody in healthcare, right? And stakeholders really value our peer support centers and our other community-based programs like Motherwise and senior peer counseling. There's some really nice quotes on there. All right, next slide, please, Johanna. Okay, so here's some challenges. Of course, you always got those. So obviously staff shortages, which are linked to recruitment and retention issues. Our vacancy rate isn't the worst, and it's certainly on par with the rest of the state of California in terms of behavioral healthcare provider vacancies. However, it's still a huge problem for us. It's one of our biggest areas of growth and need. I think in the next 3 years, there's a lot of energy in this space, and so I'm really hoping to tap into some statewide initiatives to help us address our recruitment issues and really staff up sufficiently. Barriers to accessing and participating in services. So of course, despite the fact that we do try to provide transportation is tough. It's just tough in this county. Not everybody also has internet access, so that's difficulty in serving this county. We can always improve, as I think any healthcare agency can, with regard to the provision of culturally competent services. Behavioral health as a discipline is kind of on the forefront of cultural competence and justice, equity, and inclusion. And it's an area of continual growth, so we take that feedback very much to heart. Despite the fact that we do have timely access, it is still reported that the perception is too long. So of course, we'd love eventually to have same-day access to services. That's a dream that I have, and maybe someday we'll get there. I don't know. So I agree with the community in that, and we're going to work together to figure that out. COVID-19, obviously changed everything. So I think that's about the biggest needs that were identified in the stakeholder process. Johanna, next slide, please. Much. The following populations were identified as those really the most in need of services and support. So here we have our unhoused populations. A lot of energy in the county right now for serving that population. Co-occurring issues, which I again stated was the mental health and substance use disorder issues is co-occurring. School-age children and families, parents. There's a lot of work actually happening in that space in Lake County that I'll speak to at a different time, and I don't disagree that this is a huge need, so I'm really pleased to see how our county's stepping up and look forward to telling that story soon. Also youth, and particularly youth of the LGBTQ plus, the letter that they struggle. There's not a lot of services and support, so I do want to give a big shout out to the Harbor on Main that we contract through for Peer Support Center Services. Redwood Community Services operates it, and they really do a great job of trying to meet that community where they're at and provide a safe space for community for those people. They actually held a really great I believe they called it Queer Prom, and I think it happened at the Soper Race Theater. So that was one of the things that happened through MHSA dollars, which is an incredible thing for our youth in our community. Also, undocumented populations, older adults, non-English speaking communities, especially the lack of bilingual services. It's always something we desire to hire, and so that's one of our areas where we're really trying to also grow within. Populations in rural areas, we're not alone in that, but there are just, rural areas make access to services more challenging. So those are the biggest populations in Lake County that was identified by our stakeholders. All right, next slide, please. All right, so they also came with some strategies, and these were sourced from our focus groups, and also from a review of what we've done before and where we can go. So improve staffing, such as behavioral health system navigators and community health workers. So we are recognizing that we're not alone in this. We have a lot of community partners who have these staff as well. And so I think we're really focused on expanding our community network of providers as a way to try and meet some of these workforce issues. Continuing to address barriers in transportation. I know that our team was recently alerted to some benefits we weren't previously aware of through Partnership Health Plan around transportation. And so we're continuing to do environmental scans of resources and make sure that we have all of those so we can connect our beneficiaries to everything they're entitled to. More telehealth supports. And different clinic locations, home visiting options, things like that. So duly noted. Service coordination. I don't think we're ever going to get to a perfect place of breaking down silos, so it requires continuous, persistent effort to make sure that we're coordinating appropriately. Also improving our, and we're working really hard on this to improve our kind of electronic tracking of data. And so that's happening in a variety of ways. Avoiding silos, aligning with community health improvement plan. Also workforce education and training. We spoke to all of this already. Workforce incentives are our kind of motto of grow your own. And continuing to provide cultural competency trainings. Next slide, please, Johanna. Did it do it?
Yeah.
Yep, that's it. The slides are blending together. All right, so these were some of the strategies that were brought up as potential solutions. I think I want to highlight the need for new services or the expansion of existing services. And here you can see a number of initiatives that are being developed to meet that need, like I've spoken about mobile crisis response. We've also done work around our FSP program and looking at the admission and discharge criteria, expansion of co-occurring disorder services, and the growth of services for postpartum and perinatal populations. And so other system needs definitely see a need to expand our SUD services, substance use disorder treatment services, and we completely agree. The department, as an aside, has recently met with the Department of Healthcare Services to express say, hey, we're going back to implement the organized delivery system. Not in the regional model, we talked about this before, so we definitely have an expansion on the horizon. Our go-live date at this point could not be any earlier than July 1 per DHCS, so we're really looking at having a very robust implementation plan that we'll look forward to bringing back to your board for review, probably in about 6 months at the most. So that's on the horizon. Enhanced social and community events. I do want to highlight our participation at this year's Lakeport Friday concert series. I don't know that we've ever had that much of a presence before, but we've held a booth and we bought a banner at that. So it's been nice to be out in the community. I actually staffed one of the booths one evening myself. So we definitely hear that. And I definitely do see just personally myself that there is still a lack of visibility about the services and supports that are available. And so that's our job. The onus is on us to spread the word, and that's something that over the next couple of years I want to get a lot better about so our community knows what they're entitled to. Next slide, please, Johanna. All right, section 4, which I believe is the last section. Is that correct? All right, thank Yes. So what are we proposing for this new 3-year plan? So it didn't come from scratch. We're just doing some modifications on some things that are working, and that's kind of our motto. If it's not totally broke, don't fix it. But there are some new things. So we are modifying our crisis access continuum. Pretty obvious because we do have my mobile crisis response going live January 1. So we're trying to have some alignment in programs and funding to support that. Our forensic mental health partnership will continue on, as well as our full service partnership. We are adding a Native American peer counseling program. And Scott, I wonder if you'd say a couple words just briefly about that.
Sure. One of the, through the community planning process and community feedback that we received is there is a strong need to help our Native American community, especially for them to do kind of peer counseling themselves. It was strongly requested for that. And so we added that within the plan that will be associated also with our Circle of Native Minds.
Okay. We're also modifying our trauma-focused co-occurring program, our outreach and engagement. It's expanding. Do we have another van in the budget? Yes, so we are doubling down. We're getting another van, and so that will be 2 mobile outreach vans out there. Going to serve. All right, so on our PEI, the one thing that we modified was our outreach and engagement, and that ties into, I think, the van as well, because they're kind of interconnected there. And also the...
Also the crisis access, the mobile crisis. The outreach and mobile crisis will be working together to be able to serve our county, the goal being to be able to do it 24/7 a day. Actually,
the requirement is to do it 24/7, so we're going to see. We're going to try. Okay. We talked about CAP facilities, no changes there, and no changes to our workforce education and training plan either proposed. All right, next slide, Johanna. So much. So this is just a summary of the changes that we've already described. Next slide, please. Much. And so this is the money. This is the money associated with every year of the next 3 years. And the money is represented to projections done by preeminent consultants in this space around what the MHSA revenue, so it's looking at tax revenue and how much we expect to receive from those 1% of earners, and that's what these projections are based off. Obviously, they can and have changed. MHSA has done really well over the past couple of years. Despite the pandemic, it did not appear to impact our MHSA revenue. In fact, we saw pretty good returns during that time, which was very interesting and good. But yet we tend to be pretty conservative and definitely keep as much as we can in reserve to anticipate the lean times, which inevitably arise.
Right. Yeah. As you know, I mean, California taxes are very volatile, depending on the economy. And the projection is also a lot of volatility. And so our budget is kind of designed to go, straight across the middle of that, recognizing there's going to be ups and downs. And so we try and keep it fairly steady, recognizing that. The nice thing about MHSA is they give you 5 years to spend a particular year. And so because of that allows for that stability.
Much. All right, next slide. Great. Well, that's our presentation. I hope that it was enjoyable. And any questions?
Thank you so much for that. I know a lot of work goes into these plans, and it's kind of like the Golden Gate Bridge where you get this approved and then you start working again. And so I just really want to appreciate everything that you put into this. Do we have questions from the board? Supervisor Spatier. Oh, dude.
Please start with Supervisor Green.
His pen's not up.
Oh, I always start.
Oh, I can go. It's a real quick question.
Please.
And this kind of goes back to a recent COC meeting. So on slide 9, I think there was a metric about the ability to connect with our Native American populations. But in that recent COC meeting, what really struck me was just a really disproportionate amount of unhoused Native Americans. So I know it's not a direct correlation between unhoused individuals and those suffering or at risk of suffering mental illness. But that number still kind of haunts me from COC. So I'm really appreciative of this new peer counseling program. I'm definitely appreciative of the new van outreach. But I'm just wondering, are there challenges, existing challenges right now that are really hampering our ability? Like, where does the county efforts end? When does tribal health pick up? So I'm just kind of wondering about the true interchange and our real ability to meaningfully engage with our tribal communities. This is great as far as it goes, but I was kind of watching the COC, and maybe that kind of highlighted to me we do have challenges in connecting the dots on those services. Can you speak to that briefly?
Yeah, we don't have enough time today to unpack that. It's a lot. What I'll say is there's a lot of water under the bridge across America. We're part of that. We're a microcosm of society, right? So those kinds of challenges we see and we interact with. And so I think there's a lot of grace and humility that from our staff about trying to be genuine and engage. But these directly, the proposed programs come directly from the stakeholders, which is the greatest part. That's how you have the most buy-in. And so we're continually looking at ways to expand our service to that population. And it is truly a tragedy that they're proportionate to the share of population for Indigenous folks, that they experience homelessness much more than is proportionate. And that's true everywhere, unfortunately.
Supervisor Spatier.
So I have a lot of comments and questions. To me, this needed to be reviewed in parallel with the EQRO, the last report that we had. And some of the things that were in there, I'm still not seeing in these numbers. And I get it that it's to me, more importantly, an issue of technology or an issue of software. And I mean no offense, but I'm just going to be blunt. I have no idea if we're doing good. We're reaching out, we're touching people in a good way, but I have no idea if we're changing lives. Because this came from the EQRO, the MHP, which is us, neither measures clinical and or functional outcomes of beneficiaries served. So I don't know if they've left our care in a better place or if they just left our care and we stopped seeing them. I've been asking for outcomes since I began, and I understand the difficulties of providing that. But all I have in the prior years and this upcoming year is how many people we served, how much money we spent, and how much money per person we spent. There's not much to tell me if the money was well spent or if the money was not well spent. I can't value each program, and I feel the need to place a value on individual programs, say, yes, I want to fund this program. It's doing so much to help change. So I hate the INN at 5% because I feel the INN needs to be at least 30% or 40% because that's where innovation and software and technology will come into play to provide us the information we need to really understand what's working and what's not working. I was just speaking to my colleague, Supervisor Crandall, this morning. It's like going to school and saying we had 500 kids in English and 500 kids in math and 500 kids in history. We're doing good. Well, no, are they going above and beyond proficiency? Are they proficient or are they below proficiency? I need to know what's our grade on these programs, and I can't place a grade based on the information we have. I want to support you in getting there. I don't know what that is, if that's just upgrading our software. I know we're working right now on our EHR, which is our electronic health records. But we can upgrade. Are we going to get any information that comes out of that upgrade? Does it have a simple report that can provide that information? And then I'll read another part from the EQRO, which I think is an important part. It was some of the, in the summary, potential roots of some of the issues we're facing is insufficient tracking, exchanging related data to make person-centered, data-informed decisions. And that's what I feel like I'm here to do. What we're here to do is the data should lead us on which programs should we support and which programs should we ask for change, or just say the program's not working, let's move on to the next. But just knowing how many people are served and how much we spend doesn't tell me how much we're actually making change in our community. And we're looking out in our community, we're driving around and walking around in our community. There's many factors. It's not just the existence of behavioral health, but I'm struggling to see us making headway, and it's difficult. So I really want to figure out, how do we get meaningful data to be able to say this program is the best thing that we can put money behind because this is what's changing lives. And I know that there's been work on it, but it's not there, and we need to get there. Let me keep going down my list. You stated something about getting to people sooner to get their service. And one of the things that was from the EQRO was 82% of non-urgent requests for service resulted in an offered appointment in 10 days. Only 1.05% resulted in a delivered service during that time frame. That is not a crack. That is a giant chasm of pitfalls for people to not get access to the services. Now, granted, they could refuse the service and not show up. And I know that you said we're working on that. I feel the need to ask to come back on a quarterly basis. How are we ensuring that when we're asking 82% of the people in non-urgent requests that they are being seen, rather than 81% of those that are requesting it are not being seen? That, to me, changes the outcome a whole lot. If we're not seeing them, it's a difficulty. So I would like to not have an annual report or a every 3-year report. I think this is too important not to have a more often report to the board to show the progress we're making and what efforts are being made to reach the progress we should be making. The EQRO report, I think, was brought to us, I want to say, 1.5 years ago. And so I'm struggling with that. The ODS, I'll just be honest, very disappointed that it's July 1st, 2024. I understand there was some difficulties, but that helps expand some of the level of access. And I know that, again, there's some outside forces, but that's a frustrating thing for me. In your 23-24, obviously speaks about it in the past as well, talks about school-based mental health services and crisis team. I'd like to get greater detail. I won't put out names, but I know in speaking with a administrative educator, they won't call you guys because they'll get the input of call the sheriff. Well, no, it's not a criminal activity. Somebody needs help. They're having a crisis. I've had that happen from one of our homeless shelters in the city of Clear Lake, where they called the crisis team, and the crisis team said, call PD. Well, that's not what. So I want to check in on some of these things more often than not, rather than allowing it to continue to better understand it, to better support it, to better get it to where we need it to be. And whether that's staffing or not, how do we continue to support each other to get there? Because these are the people in our community that are falling through the cracks. I'll bring up two last things. One is jail. I know that we did do a new contract with Jail Medical, but I also feel there's not this full blend of your patients, your clients, whatever's the right term to use, that end up inmates in our jail system. The fact that it might be WellPath that sees them instead of maybe their usual folks from behavioral health. I just want to make sure there's an overlap, and I don't understand what that overlap is. I know we've constantly been working on it, but again, those are numbers that I think I would like to address to make sure that there's no cracks. And then the last thing I'll bring up is something that was brought up in Hope Rising. It's something that I've discussed with Supervisor Crandall and our CAO Parker. And it's kind of alluded to a little bit here in the sense of better outreach to different populations. And I know that you do an internal sensitivity training within your department for your staff, but let's be real, the majority of the services we provide is through contracts. Maybe not the majority, but we have a huge array of contracts. How do we ensure that all those contractors have that same level of sensitivity training so that they can be just as welcoming, just as understanding of different cultures and different people's walk of life. I want to make sure that they're getting the same level of training and even looking at enhancing our training rather than whatever training it is that they did to be able to check that box. So I just want to, I think that we need to have more conversations. And I've said it before as well, this is not just you. The people you care for are part of public health issues. The people you care for are part of social services issues. The people you care for go through our justice system. I'm not looking at you individually as the answers, but the problems that you're dealing with is so much more holistic than just what you can handle. And I know I'm trying to wrap my brain around how is it that I can bring everybody together without violating any of our, how many hours I'm taking up before it goes to the board, because all I can bring to the board is a blank slate of let's do better. But I need the conversation to continue more often because we can do better, we should do better, and we need to better know how we can support you to get there. So those are my comments, and I guess I don't have any questions other than if you can describe what you're doing to better offer outcome data for us, and how to ensure that we fix that gap where only 1% of the 82% we're seeing within 10 days. And I know you kind of discussed that a little bit too, so I'll stop talking.
Appreciate all the feedback and certainly the passion and energy for the work. Now, with regard to outcome data, of course, we did present a piece of outcome data on a very expensive program, full service partnership. So I thought that that was fairly compelling. Now, across the state of California, especially with the rollout of the semi-statewide electronic health record through CalMHSA, that's one of the cornerstones, I guess, of the project, you could say, is to provide very transparent, real-time, accessible reporting around outcome data. Now, individually, on a program basis, like, for example, our early psychosis intervention program, we have quarterly reporting that we complete with the grantor that does involve outcome data. Now, some of that is quantitative, and a lot is quantitative. And so I would also like to just give pause for the idea that there is value in qualitative data and report. So there's that definitely awareness, again, not just with our mental health plan, but within the broader space in California behavioral health. So I anticipate significant movement, especially with the advent and implementation of interoperability, which is where a patient can go in and access their own chart, right? Pull their own documentation in real time, and also a health information exchange, which allows us to exchange in real time data with like our hospital providers, and other healthcare providers to better coordinate care. You spoke to a lot, Supervisor, and I definitely appreciated it, and it resonated with me. I do think that it's larger, obviously, than just this meeting. There's a lot happening, and so be happy to follow any direction of the board as regards further reporting.
Supervisor Crandall?
You probably covered this, just a lot of information, but I wanted to go back to the budget request where it says MHSA expenditure. Is that what they're recommending from the Services Act, or is that what you're recommending?
No, that's we make that based on projections that are provided to us, so we've done our own work around that.
And then the total expenditures is what you followed? And
Right, yeah, the total expenditure also includes Medi-Cal, because a lot of MHSA can be leveraged for Medi-Cal. And so there's the MHSA column, which is just what we receive from MHSA, and the full expenditure includes Medi-Cal as well.
Okay. And yeah, because I've noticed like some of the differences, like in the INN program, it goes from 37.5 to 410, things like that. So I'm just like, I think you probably explained it.
And that's reason because one of our innovation programs is decreasing, and another one will start up, and that's why it booms up again.
Oh, okay. All right. Yeah, I just, I see the CSS programs are heavily funded, and I know that we need to maintain. I just think the PEI could heighten a little bit just to kind of catch people ahead of the road.
Hold on.
19%.
Okay.
It's funny you say that, because actually in the proposed SB 326, that's one of the items that they want to cut.
Really?
Just saying. anyways.
Wow, okay. I mean, I'd rather catch them ahead of, yeah, all right, thanks.
Okay.
Just to talk about the mobile vans, getting out there, seeing the communities. I did see, I don't know if it was just temporary, but Middletown. I didn't see Cobb on there either. Do they, you guys got a site up in Cobb?
Thank you so much for that question. So no, we don't have one in Cobb. In our Middletown, we did stand up a site there, and it just, nobody came. And so it became not very cost effective. They did a lot of PR too. They went out and kind of pounded the pavement to try to get people aware. And so because of that, we're looking at when the lease does term, is to get out of that facility and look at another place, another way. So we put those staff and staffed them up at like our Big Oak Center, which has they need help. And so we kind of, that's what's happening there.
Well, we're talking about two different things, right? The van goes and meets people where they are.
Correct.
So we have the Friday night market that is very well attended.
Yeah.
On Friday nights there. You know, obviously, also looking at the mobile vans, we're looking to get to the most vulnerable community.
Oh, you mean the van going? Yeah,
The
of
van.
course, of
That's what
course,
I'm
of
talking about,
course.
the
Yes,
van.
of course. I'm so sorry for that. Yeah, because we did have a center in Middletown. No, the van, especially with the additional van, for sure. For sure. We'll go wherever we're called. And so, Scott, let's make a specific effort to reach out to, maybe there's, shopping centers. There are hardest stores in Cobb. Anyways, there's places.
Yeah, and I had those conversations before with the previous director about getting them in some targeted areas.
Great.
And when there's a lot of folks there, I think the Friday night markets, I think Grocery Outlet too is doing Sundays now. They still have their market there too, quite well attended. I think also too, I've mentioned, I think even last year when we were looking at our, we have the Gleaners, we have the Redwood Food Bank, we have a lot of food distribution going on around the county, making sure that we have a presence there because they may be in line getting the food, but we know most of those homes are being affected. So
We
just
host
making
one.
sure we're kind of, making the way around the county because they may not make it up to the Clear Lake giveaway, but they're, in South County. So just making sure they're there, it's visible with the vans and other things like that. So just, sometimes it just takes point of seeing it before we get those new folks that are interested in having that conversation.
That's definitely our goal, is to do that. We also attend a lot of the events that are around and have them put booths and tables up with referrals and flyers and things to get people's attention. Elise mentioned the concerts in the park that we are attending this year. Then, like I said, the newer thing that we have is the van, which gives us even more capacity to go to different places as opposed to just, some event. But, it is definitely our intention, which is why we're getting another van, to increase this ability to do this.
Okay, I will open it up for the public. Do we have anyone in the chambers? Come on up.
Okay.
Joan Moss, as usual, I have two questions. I want to know how many suicides occurred in Lake County, and if the number has gotten down, and how many suicides in the jail. And I want to know if you know what diversion involves. I heard in a court where a gentleman, he'd gone to a trial in front of the state attorney general, and he was back. And he was being considered for diversion through mental health. And I want to know if you know or where I can find what a program called diversion, is that through mental health or behavioral health or through the Justice Department? Thank you. So I want to know about the suicides, and I want to know about diversion.
Sure. So maybe this is something that you can talk offline about since it's not directly related to the plan that we're about to adopt. Got someone else?
I would say the plan has not a lot to do, but is absolutely connected with the potential of suicide rates.
Right.
Because even EQRO mentions some of the downfalls and our numbers for suicide rates.
Go ahead.
Good morning, Supervisors.
Good morning.
Patrick Wrights, Fire Chief, Lakeport Fire Protection District. I want to speak to the issue at hand that law enforcement was mentioned and getting them some assistance. When folks are in crisis, 911 is called, law enforcement may or may not be dispatched. EMS may or may not be dispatched, but quite often we are dispatched and we're asked to handle these patients who are in crisis. And we have not seen the ability here in Lake County of being able to reach out and get some help immediately. Our only answer is attempt to get them to load up and transport to the ER where they AMA and they're back on the street. And they really may or may not want the care, or they don't feel that the care is efficient, and ER doesn't know how to handle these folks. So there is a definite hole in the system. We have 2 individuals in town in Lakeport that are in crisis every day, and they're still on the street, and they're still in crisis. And law enforcement can't do anything about it. Fire and EMS can't do anything about it. And these folks are terrorizing our residents and terrorizing our businesses and causing a whole lot of problem up and down Main Street. And there's not one thing any of us can do. And I'm looking to a carve out, if you will, when we're talking budget numbers on these issues, to get some assistance to your first responders, to get us better trained, to get, Lakeport PD has been able to get a behavioral health person with them that, unfortunately, when we've had calls, the majority of the time that person's not available. They've timed out, they're not on that day, whatever the particular issue is. But my folks, we received some basic training in our paramedic school, in our EMS, and then it's up to us to get the rest of it. And I've asked and reached out in other counties, and I'm a short timer here, I've only been here 10 months, but I see a huge issue and a huge need that we've got to get our first responders better trained, and we have to have a better network and a better line of communications to get these folks the care that they need and the family support that they need. And we just don't have it. It's not there 24 hours a day. It's not even there. If we have a crisis right now, if there's a 911 call, that person's going to be transported to one of 2 places if they're transported at all. They're going to jail or they're going to the hospital. And we know they're not getting the care. So help us help you to help them, is my request. Thank you very much.
Thank you, Chief. Did you have a response?
Would love to connect with you offline. We can have discussions. There's a lot of work happening in this space, so I'd love to help inform you.
I would appreciate it, because if I'm not saying it's not being done, but it's not being communicated to us. So thank you very much.
Thank you.
Michael Wegner, thank you, everybody, for everything that's been done to get us to this point. I just wanted to follow up with the chief's, I think, point about the things that do go on and the things that get put onto the fire district's desk or in their office, and they're constantly trying to take care of a lot of different issues. And it's really consistent that they just don't have enough manpower, which usually turns out to be not enough money. I think that this is something that's really consistent and not anybody's fault, but I think looking at ways to help support him or just fire districts in general, I think have to come to the front of the line. These are really important issues. Behavioral health and physical safety is of the utmost importance if we look at any aspect of life in Lake County. So I would stress the money aspect for the departments that are being utilized in all their capacity. Thank you.
Okay, thank you. And we have a hand in the Zoom room, Carrie Manning, if you want to unmute. You can state your name and have 3 minutes.
Good morning, Carrie Manning, and I work for Lake County Behavioral Health Services. And I just want to assure the board that the outreach efforts are increasing. And as we have, I just assigned staff to go to Middletown with the van and bags of food from some of our, food distribution that we do 3 times a month at the 2 centers at Lavos and the Oaks. And that's going to be starting here very shortly. One of our challenges is, providing continued services at the centers while we're also doing the outreach. And so I know that we are planning on hiring a couple more people specifically for outreach, but someone will be going to Cobb and Middletown and driving through Hidden Valley. And we already go to Lower Lake, Kelseyville, Lakeport, Upper Lake, Nice, Lucerne, and Clear Lake. So, Middletown has just been hard to get to, but we are making that a priority now. So, and on the outreach van, we also take, like I said, the bags of food. So I just wanted to assure you that we are addressing that. And thank you very much.
Thank you so much, Carrie. Okay, it looks like we're finished with public comment, so we'll bring it back to the board. Ready for action? Supervisor Spatier.
Just wanting to ask if there's consensus for this type of conversation, and update on the progress made on the MHSA plan over the course of 3 years. Can happen more often, maybe every quarter, maybe every 6 months. Just everything's connected. We have a sheriff who is constantly trying to figure out how to get more correctional officers, and a lot of the people we send to our facility there have mental health issues. So how do we ensure that we can take care of that up front so that maybe we can decrease the number of mental health issues that are being dealt with in our facility? We're always talking about being short-staffed, and we're talking public defenders and trying to figure out how to deal with that. A lot of the times, our public defenders are dealing with people who have mental health issues. I just think there's a lot of interconnectedness here that we need to make sure that it comes. We talk during contracts, but we don't talk MHSA plan as often as I think that we should. So just looking to see if there's a consensus from the board to bring it back more often.
I agree that we should talk about it more, but it's still pretty broad. And I think quarterly is probably a little too often, but I'm okay with having the discussion and looking at ways that we can see more of what's actually happening and reporting. It sounds like that's what you're looking at, but I don't want to have it too broad where we can spend a whole day and get really off track. So I just want a little bit more specific, and maybe twice a year at the max.
I'm okay. If it's agreeable to the board, looking at every 6 months and have staff come back on what kind of reporting they would like to offer.
Or maybe share some programs that are really working. Why don't we let staff answer?
May I? So we are planning to come back, and it's my apologies. We normally would have came to the board a couple of months ago with our EQR, our most recent one. We did have one, and so if it's agreeable to the board, perhaps that could be a suitable midway checkpoint to bring back that report, and of course contextualize it within the intersection of MHSA and other stuff. I also want to I'll take this as a shameless PSA. Chief Rasmussen has been organizing, Lakeport PD has been organizing a community meeting on homelessness. I know he posted it on social media, and so there's a lot of energy and discussions to be had about that. So I encourage anybody to attend that community meeting that will be held in Lakeport to talk about a lot of those types of things.
Okay. So consensus to bring this back?
Yeah, I think 6 month, I'm good with that, mid-year. Obviously, sorry. I agree with that.
Okay.
I'm good with what Director Jones mentioned as well in regards. Sorry. Regarding the EQRO as a segue, so yeah, 6 months is great.
Okay. And Supervisor Green, you have your pen up?
Yeah, thanks. There's a lot of data points, so if we're asking them to report back, we should really throw them a bone and say which data points are really most important to come back. Some of these are going to be annual reports. They need to wait for the data to come in from their various streams. So just real quickly, I want to refer people, there is a 221-page report that was prepared by the consultant RDA. It's a good read. It contains a lot of the individual programs in a greater breakdown. I did have a question on page 149 of that breakdown. There's reference to a multi-county FSP. I think that's probably a copy and paste error on the consultant's thing, so I don't need an answer to that question. To the question raised by Chief Wright, and I've had extensive conversations with Chief Rasmussen as well, the whole reason that grant position with Lake FRC happened was part of a perceived failure that despite repeated outreach to BH, we were not able to get real-time response to people in obvious mental health crisis. That said, and I appreciate that there are 2 positions being added for crisis response, but I want to be very clear, we need to grow capacity in that area, but it's also not going to be practical or affordable to staff up social workers on a mass basis for ride-along programs with our law enforcement and fire agencies. That said, I want to reinforce what Chief Wright said earlier in the previous discussions. I appreciate the growth in this crisis response model. I don't think it's going to be enough, and so I want to, if they didn't make clear the expectations, that is kind of the expectation, is we are going to grow capacity to do real-time response. And it may not be good bang for the buck because they may respond and that person may want to get transported or may want to enroll in services and stuff like that. But the main point is, to the extent we're growing BH services for crisis response, that's good as far as it goes. We need to signal to our law enforcement and fire agencies apparently now that they need to grow capacity within their systems because BH won't be there every time they call. And so in addition to bringing back a report every 6 months, that I think we can focus on crisis response because that is one of the biggest touch points in this report and the biggest topic of discussion I hear about. Maybe we could refer a standing item to Emergency Medical Care Committee, which already does deal with things like transports and stuff like that. I don't know if we have gone front and center before EMCC to have kind of a running temperature check of not just how we're running buses to the hospitals, but what they're running for. So, we would be very interested in trauma at EMCC. I don't know that we've spent a lot of time talking about mental health response at Emergency Medical Care Committee. So I wonder if there'd be consensus from the board to refer kind of a standing agenda item to EMCC.
I may provide some clarification and respond. There's significant activity and energy happening. So we actually meet monthly for the past few months with Sutter Hospital, as well as Lakeport PD, as well as the sheriff. We've also reached out to Chief White in Clear Lake to collaborate and sit at one table to talk about these issues. These are our community members, and we need to sit as a community to talk about them. And so I'm pleased to see Chief Wright's come, and I'll be happy to reach out to him and include him on that. So we're also in discussions with them in developing an updated MOU with the hospitals for a community countywide involuntary response process, crisis response process. And we will be coming before your board here in the next, I want to say by November, probably, to review the Mobile Crisis Response Implementation Plan and to pass a resolution authorizing the director to sign and submit the Mobile Crisis Response Implementation Plan. So I want to just also provide some context here that the Mobile Crisis Response is happening in California because all California counties are struggling with that. I also want to say it's not just unique to Lake. I understand Lake has some unique challenges, and we're here to meet those challenges, but there's a lot of statewide energy around fixing these issues systematically, because that's what we have is systematic type issues that intersect with social determinant of health. And so to the end that to the extent that we can break down silos and sit at a table with each other and talk about these things, behavioral health continues to be a very willing, receptive partner, and we are always here to support our law enforcement partners especially.
Excellent. So we're going to look forward to that in November. Great.
Well,
Okay.
just to follow up, is that kind of an ad hoc thing going out? So again, silos, I didn't know about that, so, and it wasn't through EMCC. So are you guys
We
going to?
do participate in EMCC and IFT as regards the interfacility transfers of patients from hospitals to acute settings. And so, yes, we do have, we do meet regularly and coordinate with them.
Thank you.
Okay. Ready for action?
I offer the resolution.
Supervisor Simon,
Yes.
Supervisor Sabatier,
Aye.
Supervisor Crandall,
Yes.
Supervisor Green,
Aye.
and Supervisor Pyska.
Yes.
Thanks.
Supervisor Spatier.
Just a final comment. Staff picked out specific items from the very large report. We weren't here for 5 hours going through every single page of the MHSA plan over the next 3 years. I would suspect that that would be the guidance given to them, is they need to pick the data to bring back to us on what progress is being made and what to talk about. We can ask questions, and maybe that can alter the next presentation, but I don't, there's too much in one document for us right now to say, this is what we want you to report on. I trust that staff knows the importance of each sector of that plan, and that they will bring back what needs to be brought.
We're trying to sew with the golden thread here.
Great. Thank you. All right. Well, thank you both for joining us today.